arterial tortuosity is a little bit of a mixed bag. Everyone, when you see a patient with Loeys-Dietz, some have a very tortuous carotid, but the vertebral might be normal. The abdominal aorta might be tortuous, but the carotids might not be as impressive. And certainly a message that I give very commonly when I'm seeing patients in my clinic at Hopkins about Loeys-Dietz is we really have no evidence to suggest that arterial tortuosity in and of itself will put them at risk for a dissection. So this is particularly relevant in the carotid artery, where if you had a carotid artery dissection and the flow through the carotid artery was made immediately abnormal, well, that would put someone at risk for a stroke. And certainly carotid dissections are associated with a significant risk for stroke, and our standard management of that in patients who don't have a genetic syndrome is to have them on blood thinners, which is Coumadin. I say it again, we have not seen that arterial tortuosity in Loeys-Dietz in and of itself lends to dissections within the carotid artery. We think that this is a biologic event. This is related to the TGF-beta, but we have not seen carotid arteries unravel with dissections as we have seen at the smaller diameters on the aortic root. So I think that that's an important thing to keep in mind. I know when you go to see vascular surgeons who are probably not as informed about the subject, they might raise that specter and say, well, this artery could dissect, we should fix it, or we should straighten it, or do things like that. I really feel there's no reason to move forward with an operative strategy in that fashion. A tortuous artery is something that we've looked at for many years, sometimes in older patients, but tortuosity in and of itself is not a problem for dissection. It probably just indicates that this is someone that we need to keep a close eye on for the other portions where we know they can get into trouble, like the root or perhaps other aortic aneurysms. So I'll take some general questions if you...
I have two, actually. One is just about imaging. If our imaging is not done here, if it's sent to you, can you still use it in the work that you do?
Right. So I think it was talked about earlier about radiation exposures and things like that. I think that certainly I try and move people away from CAT scans towards MRI. It's more difficult to use the MRI technology for example, the high fidelity centerline measurements, but certainly we can do some very basic measurements off of MRI for vessel tortuosity and certainly diameters of the blood vessels, which is really the surrogate we use for concern of rupture and dissection. We can always pick up on MRI. So if you have those images, oftentimes they're sent into Gretchen, then Gretchen drops them on my desk, so they sort of get looked at by a lot of people through the Hopkins system. Sometimes people talk about carotid arteries and they say extracranial, which just means it's outside the cranial vault. And then there's intracranial, which just means it's inside the cranial vault. And you can have tortuosity in both of those areas. A lot of the CAT scans I looked at for this initial evaluation didn't include brain MRAs, but we definitely know that tortuosity can occur there. Like I said, the one patient did pass away many years after her original thoracic aneurysm repair of a subarachnoid hemorrhage, and we don't know if she had a brain aneurysm. We worry about things like that, and if regular imaging was done, such aneurysms could be detected if they were developing where usually it's not necessarily the tortuous blood vessel itself that develops the aneurysm, it's where the blood vessel splits in the brain. So where it comes up from the base of the neck and then splits into what we call the middle cerebral artery and the anterior cerebral artery, right in the saddle of where those two blood vessels are splitting, sometimes people will develop an aneurysm there. The good news about aneurysms in the brain is that many of them can be addressed with coiling. They don't require having to open someone's skull to get to the aneurysm. So I think there's a lot of very minimally invasive ways to address these if they should develop. But it hasn't been a big problem to see aneurysms develop in the intracranial circulation. We see tortuosity, but again, not aneurysm or dissection. Right. Well, I mean, as a consequence of aging, most blood vessels will lose some element of the regular elasticity that you had in your childhood years and teen years. Aortic growth continues to about 18 years of age. As I'm informed by Dr. Dietz, most of the elastin content is really deposited by about 18 months of age. So what you have is given to you at birth, but interestingly, the maintenance of all those elastic fibers is really the key thing. So if what fibers you have are maintained by having good medication on board at the time of an early diagnosis, you can really keep the amount of elastin working well for you for a lifetime. As you implied in your case, having the dissection sort of created a certain amount of degradation throughout the entire system and led to more and more surgeries. And that's been my impression to some degree. I had, particularly when the syndrome was first diagnosed, we saw a lot of patients and they had dissections, and of course we put them all on losartan because that's what we were thinking the way to go was. And we still saw some people grow their aortas on losartan and still come to require surgeries on the dissected portions of their aorta in the chest and the abdomen. There's no question in my mind that when I look at the dissections, I can predict, who's going to wind up with an aneurysm. And the reason is because when you have a dissection, most people tend to misunderstand that a dissection is a simple longitudinal tear running down the aorta, sort of like picking up this carpet and just tearing it like that. In fact, the aorta is several layers, and the dissection occurs in a circumferential fashion around the entire aorta. So if someone suffered an aortic dissection and the entire circumference of the aorta, or nearly the entire circumference of the aorta, is dissected running down through the chest and the abdomen, well then there's circumferential damage to the, or near circumferential damage to the entire wall of the aorta, and those patients are the ones that wind up requiring more and more operations down the road. There's no way for me to prove it because you would never want to take someone's aorta out just because they had a dissection. Many people can do just fine on medical management, but I do suspect that the severity of the dissection events is worse in connective tissue disorder patients versus someone else who comes in with just garden variety high blood pressure, which is what usually produces these type of dissections otherwise. So I don't think that just because you have a dissection and you're on losartan, that the losartan might be as protective as it would have been had you not dissected. I think a lot of the downstream surgeries that people suffer after a dissection event are purely related to just the traumatic nature of the dissection event on the aorta, and the biology at that point probably isn't really relevant to the process. It's just the severity of the dissection and how much of the circumference was affected by the dissection itself. And we've seen that time and time again. We're getting better about predicting that, and the question becomes, well, if someone had a dissection and they're doing very well from it, but we think that the severity of the dissection is quite severe, should we put a stent in that person to try and reopen and re-anneal the layers mechanically, try and push those layers back together and obliterate the dissection with a stent graft or some endovascular type of procedure? And I don't think we're there yet with that question. I think it seems attractive to say, well, if you had a dissection of the descending aorta running down into the abdomen, what we call the type B dissections, could we put a stent in you and get those layers to sort of re-anneal themselves and protect where the tear entered, and then get it to all seal closed? And we've definitely appreciated, it's not been a treatment paradigm that we've advocated. We do appreciate that if you have a stent put in, a dissection, particularly in the Marfan group, is the one that's been reported first, the failure rate of those stents is very, very high. They tend to require a lot of operations despite having the stent, and the stent introduces some mechanical issues to get the stent out when you finally have to go in there to operate. So I would not advocate for someone having a dissection who has a connective tissue disorder to have a stent placed, I think. The elephant trunk procedure is a procedure that is done when someone undergoes replacement of the aortic arch, and it's thought that the descending thoracic aorta is going to be at risk for developing an aneurysm. Technically speaking, to get through the scar tissue that it will have accumulated on the aortic arch, to then get control of this piece of aorta, to then fix it, can be very, very difficult. So the elephant trunk technique basically means that they leave a piece of graft dangling inside the aorta down the chest, and that piece of graft then can be accessed a lot easier for eventual replacement of the aorta running through the chest. So the elephant trunk, it sounds like an elephant trunk. So when you look at a picture of these schematics, there's just a graft that's dangling down inside the descending thoracic aorta. Some people become concerned about elephant trunks and whether or not people can form clot on those elephant trunks, and then that clot can go down into the legs. And I think that the likelihood of that is very, very low. I certainly have not advocated that if you have an elephant trunk that's waiting for the second stage surgery that you need to be on warfarin or Coumadin or things of that nature. I think within a week or two, most of that graft is covered with at least some form of a biologic surface from platelets and other things that circulate in the blood. So I don't worry too much about an elephant trunk sitting inside the chest waiting for years or months or whatever it takes to eventually be used. The standard replacement material is polyester or Dacron, and it's of various sorts. But if you had replacement of the entire aorta the whole way down, made of Dacron, we definitely appreciate that if the individual patches where the aorta is used to reimplant those critical vessels, like the ones for the spinal cord, the liver, the gut, or the two kidneys, if those patches are made very, very large, those patches are at risk for developing aneurysms over time, and getting to those to repair them is a very, very difficult procedure. And we see those in patients who get repairs and then they develop sort of elongation of those patches. I think there's a general understanding for those who do a lot of these surgeries now, particularly in the last few years, we've gotten away from that technique of leaving even a little patch of aorta. What we do is put a direct bypass into those vessels directly. The grafts I put in sort of looks like a graft that's about the length of my forearm, and then it's got 4 little grafts that are prefabricated to come off of it, and those grafts are used for 1, 2, 3, and 4 vessels in the abdomen. So there's no aorta left behind by the time you come through there. So the prior technique had been to include patches of those critical blood vessels versus directly implanting them as single vessels. Now I think we directly implant them as single vessels, and we'll get away from that problem. But there is no, other than that problem of the patches developing aneurysms, there's no problem with someone having an entire aorta replaced with Dacron. There's no need for prophylactic antibiotics with dental procedures or colonoscopies. Those aortas, it's very high flow. The risk for infection is extremely low. We tend not to worry about it, not nearly as much as a mitral valve or the aortic valves, where the antibiotics is probably a good idea. Right. So the question was concerning craniofacial abnormalities and the prevalence of aneurysms within the aorta. And certainly there is a craniofacial score that was included in the initial publication in the New England Journal. And most of that seemed to relate to the fact of the ascending aorta. It hasn't been worked out that the craniofacial score correlates well with the development of any aneurysms in the thoraco-abdominal aorta, or for that matter, peripheral aneurysms. The people who have higher craniofacial scores almost always will have more tortuosity of carotid and vertebral arteries, and like I said, that can look quite impressive on CAT scan, but bears no relevance to a risk of dissection within those vessels. So my sense to answer the question is those who have a higher craniofacial score are probably being monitored more regularly anyway, because of the concern for a more aggressive variant of the Loeys-Dietz syndrome. The questions concerning carotid dissection and the long-term implications. So carotid dissections can occur in patients with and without connective tissue disorders. Generally, the onset of a carotid dissection is usually treated with a short dose of anticoagulation, usually warfarin. We usually continue it for 6 months, and there's no data to say whether 3 months or 6 months or even 12 months is best. It just seems as though 6 is a number that people have settled on. Thereafter, people can have headaches from carotid dissections. It tends to be that there are nerves that run up, the occipital nerves that run to the back of the head, traverse the area of the carotid bifurcation, or where the carotid splits between the common carotid in the neck and then the external, which supplies the face, and the internal, which goes to the brain. The occipital nerves run right through there. So headaches in the back of the head, I think, are potentially excusable from the carotid dissection. You know, sort of the frontal headaches and things of that nature, I would have a harder time envisioning a pathway where that could occur.